Hello, everyone. My name is Emily Moore, and I am the Senior Analyst for Health Transformation at the Association of State and Territorial Health Officials, also known as ASTHO. I would like to welcome you to today's webinar on improving license portability through Interstate Licensure Compacts, an interstate approach to improving access to care and addressing workforce gaps. ASTHO is supporting state and territorial health officials and their leadership teams within the transforming health system. ASTHO, with the support from HRSA, is providing this webinar to facilitate the sharing of best practices and lessons learned related to licensure compacts and improving access to care. This webinar is scheduled for an hour and a half and will have time set aside for discussion with participants at the end of the webinar. In an effort to reduce background noise, your lines will be muted during the presentation and when you are not speaking. If you have a question during this call, you're welcome to post it to the participant feedback box on your screen. These questions will be answered during the Q&A at the end of today's presentation. We will also open the phone lines during the Q&A at the end for you to ask additional questions. At the conclusion of this call, you will be directed to an evaluation survey, so please take a few minutes to complete it, as we would appreciate any feedback you have to share to inform our future work. Please note that slides and recording from today's webinar will be sent to all registered participants in the next few days and posted on the website. Now I would like to introduce today's speakers. William England is the Director of the Office of the Advancement of Telehealth, OAT, in the Federal Office of Rural Health Policy at HRSA. Bill started work in telehealth at CMS and Medicare, followed by 15 years as Director and Vice President of the FCC Rural Health Care Program under the USAC. He joined OAT in 2016. He is a fellow and former Director of the American Telemedicine Association. Prior to telehealth, Bill was an Assistant Professor of Industrial Engineering at the University of Wisconsin-Madison and a Robert Wood Johnson Faculty Fellow in Healthcare Financing. He began his work in healthcare as a biomedical and electrical engineer at the Indiana University Health in Indianapolis. His PhD is in operations research from Purdue, and his law degree is from the University of Maryland. Anthony Oliver is currently a public health analyst in the Office for the Advancement of Telehealth as well. In this position, he serves as the project coordinator for both the FLEX Rural Veterans Health Access Program and the Licensure Portability Grant Programs. His previous experience includes working as the Office Project Officer for the Rural Health IT Workforce and Telehealth Network Grant Programs. Anthony also provides staff support to cross-federal work groups on the telehealth, a federal work group whose goals include facilitating information sharing and education among its members, coordinating programmatic guidance, and other materials. Prior to joining the Office for the Advancement of Telehealth, Anthony worked in the HRSA's Office of the Health Information Technology and Quality, where he developed health IT and quality improvement technical assistance products for grantees. Anthony also represented HRSA on the Vocabulary Task Force, a subgroup of the Health IT Standards Committee, a federal advisory committee that provided recommendations on health IT standards issues to the national coordinator. In addition to these accomplishments, Anthony is a volunteer emergency medical services provider with Montgomery County, Maryland's busiest heavy rescue squad company. Our next speaker is Sherry Abranovich Hickman, who serves as Director of State Policy and Legal Services at the Federation of State Medical Boards. In this role, Ms. Hickman supports FSMD's advocacy and legal departments, developing model policies, monitoring state and regulatory legislative actions, providing policy and legal support services to member boards, and supporting the legal interests of the FSMB. Prior to joining the FSMB, Ms. Hickman clerked for the U.S. Senator Dianne Feinstein's Judiciary Committee office, drafting advisory memorandum to the Senator, analyzing legislative submissions before the committee, and reviewing candidates for the judicial nomination. Ms. Hickman also clerked for the National Partnership for Women and Families, working on issues impacting the Family and Medical Leave Act, the Healthy Families Act, and paid sick days legislation. Ms. Hickman holds a BBA from the College of William & Mary and a JD from the University of Baltimore School of Law. Ms. Hickman was admitted to the Washington, D.C. Bar in 2014 and is currently a member of the American Health Lawyers Association, American Bar Association, and Washington, D.C. Bar Association. Janet Orway, Executive Director for Sipe Act, Associate Executive Officer for Member Services and Association of State Provincial Psychology Boards, and she's been there for 21 years. She served for many years as a Mobility Coordinator and Director of Member Services and is currently the Associate Executive Officer. Janet plays an integral part in the development of new services and programs, securing and managing large government grants, and furthering member relations. She is responsible for managing member services for ASPDB, including Mobility Initiative, Psychology Licensure Universal System, and the Disciplinary Data System, as well as ASPDB website and the ASPDB listserv. So without further ado, I will now turn it over to Bill and Anthony from OAT.
Thank you, Emily, and it's very exciting, fun to be here working on licensure issues at HRSA. When I first began to work in telehealth at CMS in 1995 as an attorney, it was immediately apparent that the licensure issue was going to be one of the most challenging issues to work on. Even though I was at CMS and reimbursement was the main issue, I figured that one can be solved because we just need money, and we could maybe do that. But licensure just presents all sorts of challenges in the way we think about healthcare delivery, and that was the big challenge. So here we are 20 years plus later, we still are trying to solve this problem. We've got some great speakers that are going to tell about what they're doing, and we get the privilege of funding them, trying to, at least some of their work, trying to work on this. Next slide is just a quick explanation of our office. We fund the advancement of telehealth, which constitutes 9 programs in our office. Even though we are the only office in HRSA that has telehealth in our name, there's a lot of telehealth going on within HRSA as well as HHS. And we're simply trying to keep track of what all of our is going on in HHS, but we do get to see a lot of it because at least things come to our attention as sort of a moderator. We do have a definition of telehealth, but there are lots of other ones out there. And if I could move to our programs, as I mentioned, we have 9 programs we're currently operating. Really the smallest one of which is licensure portability. That's about less than 3% of our entire telehealth budget, most of which is actually going to delivering telecare or helping promote and advance telehealth through our telehealth resource centers, which I do want to emphasize is a resource to the entire telehealth world. We provide expertise on all aspects of telehealth, from licensure to reimbursement to technology. Whatever you need, check with a telehealth resource center, look at their website. They will provide essentially free consulting. If we could go on to our next program then. We have 2 grantees, both of whom will be our speakers today. We're funding them each at $250,000 per year. We've been in the business of doing this essentially since the office was created in 2002 in the Healthcare Safety Net amendments. We didn't actually have funding to start this program until 2006. We have been funding some grantees to work on licensure since 2006, and we're getting close to, I would say, achieving success. We've got the 2 programs we're going to be talking about, plus the other very large program, the nurses license, that are about to go live. We can go to the next slide. Just to get a sense of where we were, we tried a graph of this, and apologies to FSMB. We may not have the count quite accurate. This was a quick look at where are we with regard to when did states pass licensure, adopting the compacts. The nurses had a start back essentially in 2000. All of us working on it, and I had some consulting back then with the nurses. We assumed this would immediately take off. Get 10 states on board, everybody's going to sign up. Obviously, that didn't happen. We had a slow growth throughout the 2000 range. The Nursing Compact created a new model in, I think, 2015, and they're not speaking here. They're not currently a grantee. They were back in, I think, 2007, 2008. We were funding them. FSMB with their licensure compact got started a little later, but they had a lot of preparatory work, so it looks like it took off really fast. But actually, in both cases, we're up around 25 states, and again, apologies, we may not be counting correctly. We're counting states that are also considering legislation. But the critical issue is, can we get over the hump? Can we get to a national model, which we're just ready to do in these 2 cases, but how do we get to 50 states? So next model, we then thought, let's take a look at our grantees by state. Unfortunately, our expert on mapping is on vacation, so we had to kind of cobble this together. You can't quite see sort of an intensity. The psychology license is only, I think, in 3 states, and again, apologies, I may not have that count correct. There is definitely, you can see East Coast, West Coast, there's a little less tendency to have adopted any or more than one model. The Midwest and the Western states clearly on board with telehealth and adopting the models, some of the earlier adopters. So with that, again, I shouldn't be getting involved in the details that we have a couple of experts that are about to speak on, so I will end with the contact information for Anthony and I. Anthony is actually coordinating our grantees, so detailed information, feel free to contact him, or you'll hear from our grantees, contact them. Thank you, Emily. I will turn it back over to you.
Great. Thank you, Bill and Anthony, for your presentation. I'll now turn it over to Sherry to talk about the Federation of State and Medical Boards Interstate Medical Licensure Compact, launched in 2014.
Hi, everyone. This is Sherry Hickman. Thank you, Emily, for the introduction. I'm the Director of State Policy and Legal Services at the Federation of State Medical Boards. I started working with the Federation in 2013, and I've been working on the Compact ever since. I'm responsible for the Federation's funding project as a grantee, like Mr. England said. So from that perspective, today I'll be giving a brief overview of who the FSMB is and provide an overview of the Interstate Medical Licensure Compact, how it came to be and what it actually does, and share some best practices and lessons learned along the way. I understand that there's time for questions at the end, and I can't see the chat, so if you have questions as I'm going, I'll try to keep an eye out for those, but if I miss anything, I look forward to addressing your questions at the end of the presentation. So first, who is the FSMB? We are a national nonprofit representing 70 state medical and osteopathic boards. We were founded in 1912 and now have offices in Euless, Texas and Washington, D.C., which is where I'm located. And we have a total of 185 employees. The FSMB serves as the voice on behalf of state medical boards in their protection of the public. And in 2015, the FSMB adopted a new strategic plan to better emphasize the organization's commitment to member board services. The FSMB offers a number of products and services to its members in meeting its vision and mission. Some of you may be familiar with the United States Medical Licensing Examination, the Physician Data Center or the Federation Credentials Verification Services, or FCVS. All of these are FSMB products developed and supported by the organization. And in addition to these, the FSMB Advocacy Department focuses on supporting state medical boards in their policy development initiatives and offers legislative support to our members as well. As you may know, state medical and osteopathic boards are established by state statute in the Medical Practice Act, which is where they derive their authority to oversee state licensure and discipline of their licensees. Some states have a separate board for allopathic and osteopathic doctors, but other states combine the regulation of the two, so that's why we have the 70 boards in our membership total. Generally, state medical boards assure competence and set qualifications of the licensees that practice medicine in their jurisdictions through the licensure process, and they assure that the standards for competence and professional conduct are met through the disciplinary process. And state boards typically need to receive complaints in order to open investigations, and they don't have authority or, frankly, the resources to do otherwise. And so it's through each individual medical practice act that state boards can issue a range of disciplinary actions, which also can vary from state to state, but generally are consistent throughout. So state medical boards are operating in an interesting legislative and regulatory environment right now. For many years, we've seen arguments for national license schemes. Federal bills have been drafted, particularly where the practice of medicine, usually for the purposes of telemedicine, is stated to occur where the provider is located rather than where the patient is located, in order for physicians to be eligible for reimbursement from Medicare, Medicaid, etc. And these models, they're proposed in an attempt to address barriers to licensure as the need for healthcare providers is consistently increasing. But we believe that these models would likely compromise patient safety and limit the ability of state medical boards to protect the public. So the concept of national licensure highlights, though, a very real need to increase license portability. And among the issues driving the need for medical license portability are projected physician shortages, influx of consumers in the healthcare system, particularly in light of healthcare reform, and the growing need for greater access to healthcare for individuals through the use of telemedicine. Advances in development of telemedicine technologies have also escalated the pressure on states to address license portability. And proponents of telemedicine cite all the time the time-consuming state-by-state licensure application process for multiple license holders as an administrative barrier to overcome for telemedicine to continue to grow and thrive. So when these issues were at their peak back in 2012 through 2013, in exploring ways to address access, maintaining quality and the workforce issues without compromising patient safety, the FSMB's House of Delegates voted to adopt a resolution to study the feasibility of the Interstate Compact model to facilitate license portability. And the Compact was seen as a solution that reconciled the concern of stakeholders that they have due to the varied state-specific licensure requirements, while also acknowledging the general consensus around the importance of maintaining licensure and discipline at the state level to ensure patient protections, accountability, oversight, etc. Generally speaking, the Compact was seen to be a mechanism to modify the current licensure system to better accommodate portability issues and multiple state practice and the availability of telemedicine across state lines. So what is an interstate compact? This gets a little technical, so I just want to take some time before drilling down into the specifics of the Interstate Medical Licensure Compact, specifically to give some general background on what the compact is. In the simplest of terms, it's a compact is a contract where the agreeing parties are states themselves. And since the founding of the United States, the U.S. Constitution's Compact Clause has allowed states to collectively work together to address issues of shared interest through compacts without the need of federal intervention. So a compact exists simultaneously as a contract between contracting states and as a standalone statute within state law. So they're enforceable by state law, but also by contract law. So to form a compact, you just need to have two states to be a party, but it's much more common to have compacts be drafted to require a specific number of signatories in order for the compact to take effect. So once the compact takes effect, a state will typically delegate the rulemaking authority to a compact commission, and this is the entity responsible for the administration of the compact itself. So that brings us to the Interstate Medical Licensure Compact, which first came to be in 2013 when our membership unanimously adopted to study a model. The Interstate Medical Licensure Compact, which I think for the remainder of my presentation I'll just refer to as the compact to save some time there. So the compact was, the model was drafted in order to expand access to care by offering an expedited licensure option for qualified physicians seeking to practice medicine in multiple jurisdictions, while at the same time balancing patient safety and quality care with the needs of the expanding and evolving healthcare marketplace. In developing the compact, the FSMB worked in conjunction with the Council of State Governments and State Medical Board representatives from all across the country. And this group early on in the drafting process agreed on key principles which to base the compact's enacting legislation. These principles included participation in the compact being completely voluntary for both physicians and state boards of medicine. The compact creates an additional pathway for expedited licensure, but does not otherwise change the state's existing Medical Practice Act. Therefore, the traditional methods of licensure remain completely intact. Regulatory authority for state medical boards isn't delegated. The practice of medicine occurs where the patient is located at the time of the physician-patient encounter. The physician remains under the jurisdiction of the state medical board where the patient is located. And the compact established a mechanism where if a license is revoked, other boards will automatically find out and will be able to take their own action, and boards retain the ability to assess fees. So in the first few years of the project, we saw a lot of misinformation and confusion about the compact. It's quite technical and was perceived as very new. And the misinformation kind of circled around the points that I draw out on the slides here. And so the compact does not change a state's Medical Practice Act. So in order to join the compact, states must enact the compact as legislation. However, altering the Medical Practice Act is a major concern for state boards, which I would suspect is a universal concern to any regulatory body to open up its statutory code. This turns into a huge administrative burden where there's opportunity to rewrite longstanding rules. So it was important to establish outright that the compact legislation would be a standalone chapter within the code, and it wouldn't supersede any state regulatory control or authority over the practice of medicine. The compact also does not require MOC or establish a national licensure system. It doesn't redefine who a physician is or other statutory definitions. The compact also does not circumvent state-specific rules, regulations, and requirements for renewal processes at this point either. So the compact pathway to licensure is an adjunct rather than a replacement for the traditional licensure application process. In order to be eligible for the expedited licensure through the compact, physicians must have passed the USMLE or COMLEX USA. They must have successfully completed a graduate medical education program, possess specialty certification, or have a time-unlimited specialty certificate, have no discipline or on any of their state medical licenses or any discipline related to controlled substances, and not be under investigation by any licensing or law enforcement agency. So we estimate that nearly 80% of physicians right now could be eligible to apply for licensure through the compact based on these eligibility requirements. And in some states, it's a much higher percentage of physicians that would be eligible based on the rates of board certification. Right now, 6 states, South Dakota, Massachusetts, Rhode Island, North Carolina, Vermont, and New Hampshire are above the 80% eligibility rate. And as far as the other 20% goes, most of these don't apply because of previously having disciplinary actions against them. The eligibility requirements represent the highest common denominator to ensure all states would be able to participate in the compact project. So for some states, these requirements are actually higher than their current state requirements. So the eligibility requirements here on this slide only apply to physicians seeking licensure through the compact process. And then in order to apply for a license through the compact, an eligible physician designates a state as their, a participating state as their state of principal license, and then selects other member states, other members to the compact, that their licenses, that the states that they want licenses from. And the physician must have a full and unrestricted license to practice medicine in the state of principal license, and the state must either be the state of primary residence for the physician, the state where at least 25% of the practice of medicine occurs, the location of the physician's employer, or if no state qualifies under those items, the state designated as the physician's state of residence for their federal income tax, and those are the requirements in order to serve as a state of principal licensure. So the next 2 slides offer a visual of the compact's licensure process. So as you can see, the process begins at the state of principal license, which attests that the applicant meets the eligibility requirements. Then the attestation is sent to the commission with the requisite fees. And once the attestation and the fees are distributed to the applicant's selected other states, the selected states then issue licenses to the physician. I'm sorry, I misspoke. I said it was over 2 slides. I condensed it down into 1 for you there. So the compact is administered by the Interstate Medical Licensure Compact Commission, the IMLCC. And this is the entity that enforces its terms and oversees its ongoing activities, including expansion of membership. The commission was established once the minimum number of required states joined the compact, which for this project was 7. So as soon as the 7th state enacted the compact legislation, that triggered the establishment of the commission. Generally speaking, the compact requires that each participating state appoint 2 representatives to serve on the commission, and the commission establishes the governing bylaws, rules, and other documents, establishes the technical infrastructure needed to coordinate its processes, and may raise its own funds to remain budget neutral, and is authorized to solicit and receive grants on its own behalf and assess user fees for service. Each compact member state is therefore represented by 2 commissioners. And in states that have both a medical and osteopathic board, a representative from each board serves as a commissioner. The commission began meeting in October 2015 and continues to have in-person and remote meetings with the entire commission and meetings of its subcommittees throughout the year. In April of this year, the first licenses were issued through the compact process, So it's officially working and off the ground, which we are extremely excited about. Up to now, the FSMB is supporting the work of the Commission by procuring federal grant awards from HRSA through its Licensure Portability Grant Program. As you saw in the earlier presentation, we received $225,000 in fiscal year 2016, and then we were awarded a 3-year grant of $250,000 over a 3-year term. So that'll take it through fiscal year 2019. And in addition to HRSA funding, the FSMB's foundation is also awarding funding to state medical boards to support their implementation of the compact to offset expenses that might otherwise be prohibitory to them joining the project. So where do we stand today? Right now, the compact has 22 member states. So that slide that we saw earlier was right. You had your numbers right, Bill. So that means that if you meet the eligibility requirements, you can receive a license from those 22 states. However, there is a caveat to take note of right now. 8 states are serving as the state of principal license, and 8 states are issuing additional licenses. That third bullet should say 8, not 9. And the remaining states' implementation of the compact has actually been delayed. This delay is a result of an interpretation issue about the state's FBI criminal background authorizing legislation. And this is a little technical, so for the purposes of time, I will refer you the imlcc.org, which is the project's public-facing webpage, has an explanation of the issue right on the front page. So go there if you're interested for more, and I can address more in questions. But the result is that the affected states must make statutory changes to their criminal background check statutes, and this can take some time to implement because it has to go through the state legislative processes. But as far as we're concerned, the 22 member states is a major accomplishment. I'm glad to hear that HRSA thinks so too. Like I said before, the authorizing language of the compact required 7 states to establish the compact and trigger the formation of the commission. So we were very pleased with the rate of this expansion. This happened only in the course of a couple of years, which is pretty fast as far as we're concerned. Education and outreach has been a major factor, I would say, in growing the project. We've been very active monitoring and tracking the compact legislation as it's progressing through state legislatures. We've met with state medical boards and industry stakeholders to explain the compact model. Some of these meetings have been formal presentations to our state boards during official FSMB site visits or at industry educational sessions where we've been invited to speak. But we've also had numerous informal conversations as well. This has taken a lot of resources in terms of staff time and expenses, but I think it's a huge factor in what's allowed the project to grow. There's also been press around the issue, which we track and contribute to when we're requested, and overall I've seen firsthand the importance of education about what the compact does and doesn't do for that matter. We're hopeful that the project will continue to grow in the coming years. I would say that the states that are currently members are the ones that specifically wanted to be part of a new project and be there on the ground level and be part of the development of rules and be part of the establishment of the commission, and there was perceived benefit in that. And there's a number of states who knowingly waited to join, wanting to see what the rules and regulations would look like, and they also needed concrete evidence that the project would in fact be budget neutral in order to get bills passed through their state legislative processes. So I think with respect to time, I will pass this along to Emily. I think, are you announcing, the next speakers? And I'll just thank everybody for their attention. And again, I look forward to answering your specific questions in the question and answer time, and appreciate your interest in our project.
Thank you, Sherry, for your presentation. So I'll now turn it over to Janet to talk about the Association of State and Provincial Psychology Boards Psychology Interjurisdictional Compact approved in 2015. Thank you.
Hi, I'm Janet Orwig, and I am with the Association of State and Provincial Psychology Boards, or ASPPB for short. And I am very excited to be here to talk about our Psychology Interjurisdictional Compact, and we've shrunk that down to be Sipe Act, so it's a little easier to say. So let me tell you a little bit about ASPPB. We are the association made up of the licensing boards for psychology, and we have 64 members, which include the United States and the 10 provinces of Canada. We help service our licensing boards with member services, as well as we have many programs and services that actually help the licensed psychologist. And we also have been of heavy involvement with international organizations regarding psychology as well. The association was started in 1961, and we are estimating that there's probably about 140,000 licensed psychologists in the U.S., and we are a much smaller organization. We only have right now about 23 full-time employees. We are actually very honored to have been a recipient of the grant. We received our first grant in 2012, and we are in the second year of our third grant. Our grant has helped fund actually two of our programs. One is our Psychology Licensure Universal Application System, which allows us to gather licensing materials for our member boards and do primary source verification on them, and then send them back a completed application packet that they can review to see if someone gets a license. That has sped up the process a lot for several reasons, but one being that it has allowed if someone is going from one plus state to another, those packets are already ready. They just have to do a couple of more reference forms, and then it's ready to go. And so that has seen an increase in the ability for psychologists to cross across states, as well as seeing a decrease in the requirements of time that they need in order to get licensed. And the other part of our grant has been funding Sipe Act. So that's what I'm going to talk a little bit more about today. So how we got here, we had went out and visited with our licensing boards, and one of the things we kept hearing over and over again was that they needed assistance in regulating telepsychology or telehealth. They knew that it was happening in their jurisdictions, and they didn't have a mechanism to regulate that practice. We have a program that we've had since 1998, our Certificate of Professional Qualification in Psychology, and that's kind of helped speed up licensure for already licensed psychologists, that if they had been licensed for 5 years, they could get the certificate, and jurisdictions would realize that it met experience, education, and examination requirements, so they didn't have to redocument all that information. So we felt like we had kind of helped with the licensure part between the PLUS and the CPQ program, but we hadn't really addressed the telepsychology component. And as you can imagine, psychology itself lends itself very well to a telepractice. So based on feedback from our members, we approached our board of directors, and they created a telepsychology task force that was tasked with trying to figure out the best way to help our licensing boards regulate this practice. At the same time, the American Psychological Association and the Trust, which is the major insurance company for psychologists, and ASPPB created a joint task force to draft guidelines regarding the practice of telepsychology. And what those guidelines did was kind of lay out for a psychologist what they would need to consider if they were actually going to practice telepsychology. At the same time, the ASPPB task force was looking at some principles and standards to allow our boards to have some kind of regulatory component. And what the task force started out looking at was to create a certificate and follow along, kind of along with our CPQ certificate. But one of the things that kept happening over and over again as we were proceeding was, how are we going to handle discipline? This isn't the same thing as a CPQ because you're not getting licensed in that other state. You're just practicing into that other state. And so we couldn't figure out a way to tighten up that component of our certificate. So in 2015, February, our board of directors introduced the Psychology Interjurisdictional Compact. And what that did was it allowed us to look at using the certificate that we had created, but it also allowed us, as has been previously explained, to give us that contract between the states and that legal impact that we didn't have. So it gave us that teeth that we were missing. And the goal was to allow the practice, but also to do it in such a way that we were continuing to ensure public protection. So what the compact actually does is it regulates the day-to-day practice of telepsychology across state boundaries. And when we presented that to our member boards, they thought, well, that's great, but we'd like it to do something else. We need it to do more. So the part that they felt like was also missing was the temporary in-person face-to-face part. So we added that as a component to the compact, that it also regulates not only the telepsychology, it will regulate the temporary practice of someone practicing into another state, physically going into that state and doing face-to-face practice. Why that was important to psychologists is that we have a lot of psychologists that go in and do forensic evaluations, they go in and do testimony, and the requirements across the states varied greatly as to what they could or could not do and how long they could practice in a state temporarily. So this will allow them to practice there for 30 days annually. So talking a little bit about the interjurisdictional compact itself, the part dealing with the telepsychology. So how we're structured a little bit different than medicine. We believe that, or have established, that practice takes place where the psychologist is. The psychologist will be practicing under the authority of their home license, and they will be practicing into any of the receiving compact states via telemeans. They will be practicing under the scope of practice into those receiving states, but they are practicing under the authority of their home state license. In order to do telepsychology, they will have to have an e-passport. And why we actually continued to keep the certificates, even though we went with the compact, was that the psychology licensing requirements vary greatly across the states. So what this allowed us to do was to set an acceptable level of, or acceptable standard for the states when they were signing on to the compact. They knew what they were going to be getting based on these certificates. And so it establishes, the e-passport establishes that legal relationship that we needed to have, and the compact then gives the authority for the states to actually work together and proceed if they have any discipline actions. If the part dealing with the temporary in-person face-to-face practice, we also have an interjurisdictional practice certificate that will regulate the temporary practice. That is a certificate we currently have available now. There are 7 jurisdictions that recognize that certificate outside of the compact, so this was something that we had already established. One of the things I'd like to say, for both of the certificates as well as our CPQ certificate, you cannot have had any disciplinary action. Any disciplinary action on a license will have revoke any certificate that you hold with us. So the benefits, actually what happens with the creation of our compact is very similar to the medicine compact. Is once we have our states that have enacted Sipe Act, our commission will be formed. We are only going to have 1 commissioner per state, and the commission will be responsible for creating the bylaws as well as the rules and regulations. We are expecting each state to have to pay a cost to participate in the compact, somewhere between $3,000 and $6,000, and that will probably be established once the commission gets created. So the benefits and some of the challenges of dealing with Sipe Act. So one of the main advantages that we have felt that Sipe Act does is that it allows to have increased access to care for the patients. It also facilitates that continuity of care. And one of the things that we've heard from various psychologists talking about this is like if you have a relationship with a young adult and they are going off to college and you have to end that relationship and put them with somebody else in that state where their college is, you have that relationship that has taken so long to develop, and they now have to go probably at a time when they need you the most off to another psychologist. So this would allow, if the person is in a compact state and the patient is going to school in a compact state, to continue that relationship. Because we have added the certificates, it helps to certify that the psychologists have met acceptable standards for practice. It also helps to promote the cooperation between Sipe Act states, as we were talking about with disciplinary actions and all that. They will both have, the compact spells out how disciplinary actions are to be handled. And that it also offers a higher protection for the consumer, because right now there's not that regulatory component if someone is practicing telepsychology, and this would allow that to happen. So some of the challenges. We have found that our member boards actually can't introduce the legislation directly. So some of them can, but most of them can't. So trying to build that relationship with the State Psychological Association and get that, as well as working with our member boards, we have said that we didn't want to introduce anything into a state that a member board was not in favor of. So we have been working with both groups and as well as the lobbyist of the State Psych Association. So getting those relationships built has been kind of challenging. And part of that is getting everybody on the same page. We've also found that we have some of our states and some of the state psychological associations that have another priority, that Sipe Act isn't their priority for this legislative session. They have another initiative that they would like to have go forward. And then we've also had some issues with the timing of the sessions. We at one time had legislation in several states, and the sessions ended and we didn't get far enough along. And then we've also had, because we are much smaller in numbers, developing those grassroots advocacy campaigns and getting that support and getting where people know where we are and they've heard of us. That has been a challenge that we have been facing and trying to work with. So where we stand now, we have legislation that has been passed in 3 jurisdictions. Arizona passed it in May of 2016, Utah in March of 2017, and Nevada in May of 2017. We have to have 7 states enact the legislation in order for Sipe Act to come into being. We have still have active legislation in Illinois. We did have at one time actually legislation in all 7. We could have, but like I said, the session ended in Texas and Rhode Island and Missouri without us being able to get that legislation passed. What we have going on down the road is that we are hoping to have Sipe Act up and going by the middle of next year. What we have are planning right now is we are working on a Sipe Act National Summit to be held in D.C. We are inviting representatives from the licensing boards, the State Psych Association, and a legislative representative for an educational meeting to talk about Sipe Act, as well as have information from the 3 states that have passed and what some of the information that they feel would be useful for a state going forward. We have sent out our invites to the boards, and we're working on getting the rest of our invites out. We've also heard from several jurisdictions or several states that they will be passing or introducing legislation in 2018, so we're keeping our fingers crossed that we can get up and going by the middle of next year. As part of trying to create that interaction or that advocacy part, we do have ways that you can interact with Sipe Act. We have a freestanding website. We also have that you can follow us on Twitter, and that you can also sign up for a listserv email where we will send out updates as we progress. And that's kind of all I have for right now, so I welcome any questions, and I think I'm going to turn it back over to Emily.
Great. Thank you, Janet, and thank you to all of our speakers for your informative and engaging presentations. We'll now ask the operator to open up the Q&A phone lines for participants, and so if you can ask a question, our operator will open it up, and you can unmute your phone line, or you can alternatively type it into the chat box located on your screen.
Ladies and gentlemen, if you'd like to ask a question over the phones, please signal by pressing *1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open, and please state your name before posing your question. Again, that's *1 over the phones, and we'll pause for just a moment. And we have no questions over the phone at this time.
Great, thank you. So I'll take it first from a question that we received. Licensure is a recurring challenge in telehealth. How do you think this should be handled, and how do you see it being addressed going forward? And I think that can be for all three speakers, so I welcome your thoughts.
Well, this is Sherry Hickman from FSMB, and I would just kick it off by saying that from our membership perspective, that was one of the tenets that really kicked off the Compact initiative, the recognition that the current licensure system, there is room for improvement, and it can better accommodate license portability, hopefully through the Compact, and with its mechanisms to expedite the process and hopefully address the concerns about the variations in licensure requirements from state to state through those eligibility requirements that would be consistent throughout all the member states. Hopefully that would address some of the redundancies and administrative burdens that those involved in applying for licenses in multiple states outside of this process may be experiencing.
This is Janet with ASPPB, and we looked at that as well. One of the reasons why we went with allowing this to have the one license in the home state and practice telepsychology into the other states without getting a license is that we looked at the ability by doing telepsychology to be able to be in multiple states and the cost associated with getting licenses in all of those states and expecting people to be able to do that. We have actually one CPQ holder who has licenses in about 30 states, and he estimates that it cost him about $200,000 in renewal fees, and he has a full-time staff person to do all of that. So we were trying to, as like I said, give access to care and still maintain protection of the public, but do it in a way that we felt would be feasible and people could do.
Great. Thank you, Sherry and Janet. I'll turn to some of the questions we received in the chat box. What is the cost and actual work effort for implementing the information coordinating system once the Compact is implemented? And I believe that's for Sherry with your Compact, but certainly, Janet, if you want to speak to Sipe Act and how that information is used, that would be helpful too.
This is Sherry. I guess I would need to ask a follow-up question. Is that asking how much it costs the commission to put the infrastructure in place? Or how much does it? Yeah, I need some clarification.
So, and maybe a point of clarification is that does the commission handle the information system itself, or is that something that each state needs to create? And I think they.
Oh, yeah. So the commission handles that themselves. To get it, I don't know off the top of my head how much that costs, but that piece of the project was supported by HRSA funding, so it was expensive. And no, that's the benefit of having the centralized clearinghouse of the commission, and that they handle the infrastructure, and it's not something that states are left to deal with administratively.
Great, thank you. So for both these compacts, have you done any research or evaluation in the number of new providers that are applying through the compacts, having additional licenses, or a sense of sort of the broadened workforce that these compacts open up?
This is Shiri again. So we haven't done any specific metrics. I think it's just too early to be able to tell how the compact is changing the licensure landscape. However, the FSMB does publishes a census of actively licensed physicians in the United States, which studies the number of active licenses and compares the number of physicians holding 1, 2, or 3 or more licenses, and this number is growing. Again, it's too early to attribute that growth to the compact, but we are aware that the number is growing. A colleague of mine also referred me to an interesting application of the compact. It's www.locumleaders.com, which I gather is a company that recruits temporary or part-time physicians and clinicians to fill in at locations when additional staff is needed. And right on their webpage, they provide a link to the Compact's public-facing webpage and offers for job seekers like tab on the website that explains how they can get licensed through the Compact. So that's a practical application of the project that we were excited to see and had envisioned being viewed as beneficial by the licensee community.
Thanks, Sherry. Janet, do you have any numbers to share or evaluation results from the Sipe Act?
Well, we are not actually up and going yet, so I do not have information on that. I do kind of have some ideas about how many additional licenses psychologists are getting based on. We also provide a score transfer service, and we see about 2,000 requests coming through to have scores sent from one state to another, so that's usually a sign that they're getting licensed in another state. And we also, because of our plus, we're running about 300 to 400 applications through those states that we're dealing with on that. So we see some, and through those we can kind of see, they got licensed in this state, they're going to another. But as far as what we're going to see with Sipe Act, I don't have those numbers yet until we get up and going.
Great, thank you. All right, Janet, I think this question is for you. Which 17 states are being targeted for the Sipe Act National Summit?
Okay, so we have Colorado, the District of Columbia, Georgia, Hawaii, Idaho, Mississippi, Missouri, Nebraska, New Hampshire, New Mexico, North Carolina, Rhode Island, South Carolina, Washington, Wisconsin, and Wyoming. And I think that's all of them.
Great, thank you.
Mm-hmm.
All right. I have another question here, and I may ask the person to clarify a little bit, but can you share more about the reference grants and their availability for other professions and the use and limits on the use of grant funding? I think this question may be directed at HRSA about your workforce development grant.
Sure. First, I should this is Bill. I'll mention that the eligible applicants are limited by statute to state professional licensing boards. So we've had several, I think we've awarded a total of 7 awards under this program. The awards have traditionally been 3-year awards, so under that calendar, our next competition would be in 2019, provided funds are available in our federal appropriations. Use and limits of grant funding. Anthony, do you want to comment on that?
The funds are used for activities that decrease barriers to the cross-practice, cross-state line delivery of care, and the funds can be used for activities that towards those goals.
Again, in terms of what professions, these are competitive grants, as I mentioned, limited to state professional licensing boards or national organizations, for example, of such boards. But any licensing board would be considered in the competition. Any health-related professions licensing board doing telehealth.
Great, thank you. I've received a number of other questions, and so Lauren, Kim, do you want to press *1 and post your questions to the speakers? I think they'd welcome that.
And we did get a question in queue. Caller, go ahead.
Hi, can you hear me? This is Lauren from Hawaii Department of Health.
Yes, we can. Thank you.
Thanks, Emily. Thank you for the call. Really getting some wonderful talking points to help us figure out how we want to approach this from a public policy perspective. And I've been the one asking some of the more work management, work effort issues because it is a matter of resources, and I'd like to follow up after this to get some more detailed information. But my general question is, I had heard last year that there were, once the minimum number of states adopted legislation, that rules needed to be agreed upon within compact states. And individuals in my community have pointed to the lack of rules or the rules that have yet to be promulgated and said, well, okay, let's wait and see. Let's not do this now. Let's wait and see what the rules look like. So what other major prerequisites or artifacts of governance and public policy need to be put in place by the compact? Again, I had heard that rules were the major next step, and could you please tell me what the status of those rules are?
So this is Shiri. I'll answer this since we are the only compact that has been established. The rules of the Interstate Medical Licensure Compact Commission have been written and are publicly available on imlcc.org. And I agree with you. We heard from many interested states that though they were interested, they did not want to commit to something that had ambiguous or no rules. So I think that's a really common concern for the non-early adopting states. Another tip and note is that a lot of states have budget concerns. We've tried to articulate as clearly as possible that this is intended to be a budget-neutral project, and as far as I know, that remains the same. There is a separate fee structure associated with the compact membership, and that information is also detailed through the Commission's rules. So those were the two issues from any interested stakeholder that we most consistently heard that did not choose to early adopt. And I would just like to hold out to Mr. Kim and anybody else on the call. You are welcome to contact me directly, and I can provide more detailed information.
Great.
This is Janet, and as Sherry said, we are not up and going yet. So this is Janet. So we don't have our rules up until the commission gets formed. That's when those will get created. So we don't have that, and we are kind of hearing the same thing. We have some of our boards that want to wait, and then we have some of our boards that the states want to come on and be part of that original rule writing process so that they have a little more, they have a representative at the table when those are being drafted.
Great. Thank you, Sherry and Janet, for that. And I think this segues nicely into our next question about how do you suggest working with providers and provider groups to address concerns they may have with either the FSMB Compact or the Sipe Act? Any lessons learned that you'd like to share?
Well, this is Sherry. I'll kick us off again. So I think that provider stakeholders are really similar actually to the other types of stakeholders in that any type of outside interest or support is a really crucial, or we view as a really important opportunity and has contributed, I think, to a lot of the success of the project. For providers specifically, we've had interest from large health systems who want a way to get their employees licensed faster so they can use their telemedicine services or practice at multiple locations in terms of border states. Mayo, Gunderson Clinic are two entities that were really helpful. And we are not, the compact needs to be enacted through legislation, which I think we've touched on briefly. But, unless you work with state legislatures, it's really hard to anticipate how lengthy and complicated that process is. Janet talked about it a little bit when she mentioned the bills that got halfway through and then the sessions ended. Some states don't even meet every single year. So a process that by its own nature is slow and has very formal steps that it needs to go through to even get off the ground needs as many champions as possible. So if you have a provider stakeholder like in your state that a hospital system wants this project to work, that's a great voice to speak up during the legislative process. If you have a state representative that hears that a local business or local doctors want this, that is a great way to get your bill passed. And so that is a big takeaway that I would highlight, that's an opportunity and a relationship that is to be valued and really cultivated. I don't know, Janet, is that your experience too?
It is. Unfortunately, psychologists are not necessarily in those big hospital associations. So they are some in some of the practices, but a lot of our practitioners are independent, so we haven't seen that. But I have made several presentations with nursing and about their compact, and I know they have stressed that when they're going into states, they are actually talking to the hospital associations in those states and working with that group because that does have a lot of interaction with the nurses. So I would say that is a very important group to reach out to.
Great. Thank you both. We've received another question through the chat box. Can you please clarify the FSMB prohibition on disciplines involving controlled substances, presumably pain management and opioids given the ongoing epidemic, but also what about child psychiatry and Ritalin?
I would just refer back to, I'm sorry, it's a little hard for me to not see the question in writing, but I think it's just asking to elaborate on that eligibility requirement, and really that's just to emphasize that any licensee that's not, anyone coming through the compact process cannot have any type of disciplinary action against them. So these are licensees that have not had any interactions with the board, whether, and I'm sorry, Emily, can you read the last part of the question one more time?
So it was in regards to sort of pain management opioids, and then also child psychiatry and Ritalin. And the child psychiatry might also fall in within the Sipe Act, if I'm not mistaken.
Okay. Yeah, I would just, I don't think that the eligibility requirements specify. I think it's really, you just have to have a clear record.
Right. I think that's really helpful. And and there's a similar question about medical marijuana reciprocity, which I know is also a hot topic, potentially across all states. So if you have similar suggestions about whether it's about making sure that they're in the clear, or are there different rules around of that?
Yeah, I mean, I think I saw one of the questions that was asked during registration. If there's differing requirements between the boards, what advice would we give? Can the compact be altered? So I think that this answer applies to these questions too. That the nature of a compact is that it's a contract, a binding contract between the states. So the legislative adoption, that language needs to be consistent among all the member states. So differing language cannot be added. That would nullify the agreement on its face. So as far as states that have different practice of medicine rules, such as medical marijuana and things of that nature, the state of principle, the states in the compact are issuing a license, and the licensee must practice within the rules and regulations of that state. So each state still retains its jurisdiction over the practice of medicine of its patients. So the licensees in the compact are still subject to whatever rules govern that state's medical practice. That doesn't change from whether or not they have a compact license or a license through traditional means.
Great, thanks, Sherry. That's really helpful. Are there? I encourage others in the audience to raise their question or put them in the chat box. But I'll have a couple other questions if speakers won't mind. So, as far as you spoke about a bit about the legislation and adopting the compact, and could you sort of either Jen or Sherry talk about sort of the length of time legislation takes, or sort of, there's a lot of planning processes that go into introducing legislation. So if you have sort of a time frame of getting it up and running, or at least consideration, that would be helpful. I know Janet, Sipe Act is still in the process of being going live. So take from it what you will, but it's sort of an idea about the timing of this.
Well, this is Janet. It's been interesting to us because we follow the time of when a bill can be introduced until the session ends, and we have software that helps us, keep up with all of that. But you think you're moving along, and you're watching, and it's gone through, a committee, and you've gone and testified, and then it's gone through the first chamber, and then the next committee and the second chamber, and it's going along. And then the next thing you know, the session's getting ready to end, or there's a deadline that if you weren't out of this committee, you didn't make it to here. And so I've kind of joked about, when I was growing up, we had Schoolhouse Rock, and you had the little Bill, and he's sitting on the hill, and he's just, it's making it sound really easy, and the little process that goes out, and that hasn't been the case with some of the things that we've seen. And I'd also like to say that it's not necessarily your legislation that causes an issue, that the reason that we didn't make it through any of those states had nothing to do with Sipe Act. We had full support. It happened to be in one state it was a fight between the House and the Senate, and they weren't hearing each other's bills. The other state was a three-party. The the governor was involved too, and they were having some difficulties or differences, and so session ended and things were still hanging. So it's a very long process, even though it's a very short amount of time. Sometimes the sessions can be 2 months, and so it's really quick as far as it goes. But all of the stuff that goes with it has been it's been a learning experience. So it's been quite trying. I am sure medicine feels exactly the same way.
Yeah, we definitely do, and this is a full-time job tracking state legislation for us at the FSMB. It is part of my job duties, and then we have another full-time staff member who assists me in our legislative tracking. So it's a huge bear of a job. But I would say that, really everything that Janet said I agree to, and then you have to also add on time to actually get the bill introduced. It's not, whatever the legislative session timeline is too. You have to get the support and the introduction and all of that, which can add months and months too. So when I saw the question in advance, I thought ballpark 2 years, a year and a half. Based on just like my own experience. But from when you have an internal state stakeholder saying, yes, I want this, to when it's enacted, I think, 2 years is probably pretty fast.
Great, thank you both. And so I have a few more questions. Another one is that we received through the registration a number of questions about how do these licensure compacts apply to nurse practitioners, registered dietitians. I know, Sherry, you mentioned that it covers MDs, DOs, and PAs, and other healthcare professionals, and so you have an answer for about some of these other types?
Yeah, it's a little redundant. I would say that my answer about how the compacts don't change the state regulatory structure would apply to this question too. Right now, this is for expedited licensure for physicians. So I think it would be up to, I don't think it would apply to other licensees, especially those that the board doesn't oversee.
For psychology, the compact strictly applies to psychologists. But I do know that a lot of the other professions are working on developing their own compacts to address licensure portability. So there may be some compacts out there that would address some of those, but the Sipe Act strictly deals with psychologists.
Great. Thank you. I'll pause here if there's any other questions from the audience, either in the chat box or on the phone.
We do have a question over the phones. Caller, go ahead. Your line is open. Caller, check your mute function. Your line is open at this time. Due to no response, we'll remove them from the queue. We have no further questions in the phone queue at this time.
Great, thank you. So without any further questions, we'll direct you to some of these resources. Here are some of the actual websites for IMLC. We shared the imlcc.org in the chat box, but also here's the compact as of May 2016, and then here's the Sipe Act webpage as well. So we encourage you to check those out, as well as reach out to our speakers with additional questions. So at this time, as mentioned, we'll close out our Q&A portion of the webinar. And so we will be sending these slides out to all participants, and we'll also be posting on ASTHO's website along with the recording. If you have any follow-up questions, please use the contact information here for myself and or the speakers that were previously shared, and we'll make sure that we'll receive your questions and get back to you. So thank you again for joining us. As I mentioned, you will be immediately directed to an evaluation at the conclusion of today's webinar. Please take a few minutes to complete our survey as it provides us with useful information for future projects. And so I would like to thank our speakers for their presentation. Dietitians and to HRSA for their support of this webinar. Thank you for joining us and enjoy the rest of your day.